Greetings to one and all. I am Dr. Muthukumar, Professor and HOD, Department of ENT, Chettinad Hospital and Research Institute. Today I am going to talk about the surgical management for OSA and ENT perspective. Why surgery is required for OSA? This is because the long-term compliance rate of CPAP therapy is variable and it's very low. It ranges from about 30 to 50%. And most of the younger patients find CPAP therapy unacceptable. And most common factors for CPAP non-compliance include nasal factors, tonsil size, and the palate length. CPAP therapy is also not effective in patients with gross tongue-based collapse and epiglottic collapse. In this regard, I would like to suggest that epiglottic collapse should have been diagnosed in the investigation itself, because CPAP therapy is detrimental for epiglottic collapse and it aggravates the obstruction. So, DICE should always be performed before advising CPAP therapy. So, coming to the treatment philosophy of sleep disorder breathing, which includes upper airway resistance syndrome and obstructive sleep apnea syndrome. Since there are a wide variety of surgical treatments for OSAs, the treatment for this achieving 100% cure rate is our maximum goal. So, since there are wide surgical options, the patient should be fully disclosed about the various options, the risks, the success rate, and the complications of each and every procedure. The patient should also be highlighted about the possibility of a staged surgical approach or multiple combined procedures. The follow-up evaluation should be done about 6 months after surgery, so that the success and the failure are determined only after 6 months. So, any revision or additional surgery is determined after 6 months. The surgical success criteria for successful surgery is AHI less, that is apnea hypopnea index less than about 20 with at least 50% reduction to the pre-op study, LSAT level seen equivalent to those with that of the nasal CPAP or greater than 90, marked reduction in symptoms especially of excessive daytime sleepiness and snoring. Recently, it has also been realized that the nasal factors, example, the deviated nasal septum, polyps or terminate hypertrophy, should be corrected before any effective evaluation of the upper airway for OSAs, because obstruction at the nasal level, it aggravates the negative pressure at the palate and the oropharynx and increases the severity of the OSAs. Hence, after correcting the nasal factors, the severity gets reduced and a proper assessment can be done. So, coming a quick recap of the staging of the OSA. We follow the Friedman staging of OSA, which is graded into 4 degrees of severity, and 3 important variables: the tongue position, the tonsil size, and the body mass index is taken into account. Body mass index above 40 is always graded in stage 4 disease, whereas body mass index below 40 may fall into either one of the 3 categories, 1, 2 or 3 of the Friedman's severity of the disease. The other variables such as tongue position and tonsil size determines the stage 1 to 3. In Friedman's tongue position, the mouth is kept open with the tongue inside the mouth, and if you are unable to see only the hard palate and the soft palate, the uvula and the tonsils are not seen, it is Friedman's tongue position 4. If you are able to see the hard palate and the soft palate but not the uvula and the tonsil and pillars, then it is tongue position 3. If you are able to see both the hard palate, the soft palate as well as the uvula, then it is Friedman's tongue position 2. And if you are able to see in addition the tonsils and the pillars in addition to uvula and the soft palate, then it is Friedman's tongue position 1. So, as the tongue position increases, the severity of the stage increases. So, tonsil size is inversely proportional to the severity of the staging of the Friedman staging of OSA. As the tonsil size increases, the severity decreases, because removal of the tonsil offers good effective relief from the OSA. So, a tonsil size of 3 and 4 is present in stage 1 and 2 disease, whereas tonsil size of 0, 1, 2 and 3 is present in stage 3 and 4 of the disease. So, why do we do this staging? Because we have a rough estimate of what to do. Suppose in grade 1 staging, that is stage 1 disease of the OSAs, it may require only single level surgery, whereas stage 2 and 3 it may require multi-level of surgery. Whereas stage 4, never we go for any upper airway surgery, we go for only bariatric surgery. So coming to the surgical indications, before I cover the indications, two important facts I want to highlight. One is that there is no surgical treatment which is 100% curative for OSAS, obstructive sleep apnea syndrome. By far, the tracheostomy is the only surgical treatment which offers the best results. So coming to the proper indications, it is mainly done for moderate to severe OSA where the AHI is greater than 15 with an oxyhemoglobin desaturation of less than 90, severe excessive daytime sleepiness even when the AHI is less than 15 per hour. OSA is associated with cardiac arrhythmias. OSA is associated with anatomical abnormalities, example in the nose, deviated nasal septum, polyps. In the pharynx, it may be hypertrophic tonsils, adenoids, or a large tongue base, or a floppy epiglottis. So all these conditions require surgical corrections. So the next important indication is a refusal or rejected medical therapy and a desire for surgery. This usually occurs in younger patients. However, all adult, even though they opt for surgery, all adult OSA patients should be offered non-surgical treatment option before surgery is attempted. At least a trial CPAP should be done to determine whether he is going to benefit after surgery by abatement of the symptoms. So pre-op CPAP is also mandatory in patients when the OSA is very severe, that is when the AHI is greater than 40 per hour and with an oxygen desaturation less than 80%, and it should be continued even after surgical correction post-operatively for 2 weeks before we attempt the post-operative polysomnography. So after finishing the indication, we should also know the contraindications. So these are all absolute contraindications where we should not touch the patients for OSA surgery. These are: one, severe pulmonary disease, unstable cardiovascular disease, morbid obesity, where only bariatric surgery is the treatment of choice, alcohol or drug abuse, psychiatric instability, and patient's expectation should always be assessed before doing the surgery. Unrealistic expectation is a contraindication for surgery. Coming to the surgical choices which are available to the patient, Riley and Powell Stanford protocol is the commonest surgical protocol for selecting the surgery. They have divided the surgery into phase 1 and phase 2. In the phase 1 surgery, for the nasal surgeries include septoplasty, turbinate reduction, polypectomy. Nasopharynx we have adenoidectomy. In oropharynx we have tonsillectomy, uvulopalatopharyngoplasty, zetaplasty, zetapalatoplasty, lateral pharyngoplasty, expansion sphincteroplasty. And in the hypopharynx we have the midline glossectomy, tongue-based reduction by radiofrequency as well as by coablation, mandibular osteotomy with genioglossus advancement, hyoid myotomy and suspension. Thus we have at each level we have a group of surgeries which can be done. So it's a level based surgery in phase 1. In phase 2 we have the maxillomandibular advancement osteotomy surgery. So this is the phase 2 surgery. Now coming to the concept, when to use the phase 1 surgery and when to use the phase 2 surgery. If OSA is due to soft tissue abnormalities, that is the obstruction is a dynamic obstruction. It is varying during the phases of respiration. So the phase 1 surgical, we select the phase 1 surgical treatment depending upon the level. It may be a single or multiple levels of obstruction. We do the single surgery or multiple combined surgeries. So we do the post-operative assessment polysomnography at about 6 months after surgery, and if it is a success, we leave it alone, or if it is a failure, then we treat the phase 1 failures by doing the phase 2 surgery, that is the maxillomandibular advancement osteotomy procedure. For OSA due to skeletal abnormalities where the obstruction is static, that is both during inspiration and expiration it is the same obstruction. So here the phase 2 surgery followed by, we directly go to the phase 2 surgery followed by palatal and hypopharyngeal surgery for residual obstructive sleep apnea syndrome. So coming to the how to do the surgical choices, having enumerated the surgeries, how to select the surgeries. It is impossible to direct the therapy without isolating the level of obstruction. So identifying the level of obstruction by drug-induced sleep endoscopy is an important procedure to be followed. Then the commonest sites of obstruction is at the nose, the palate and the hypopharynx. The Fujita's classification of the level of airway collapse, he classified into 3 types. In type 1, upper oropharyngeal airway pathology, where the obstruction is due to the palate, the uvula and the tonsil. Type 2 is upper oropharyngeal and hypopharyngeal airway collapse, and type 3 is hypopharyngeal collapse, that is lingual tonsil, the tongue base, the supraglottis and the hypopharynx. So Performing an uvulopalatopharyngoplasty operation for a retrolingual collapse, that is type 2 and type 3, where the obstruction is at the lingual level, it will result in a poor success rate, because palatal surgery is at a higher level. So the obstruction is at a lower level. So it is inappropriate. Hence, appropriate surgical choices should be done according to the level of the obstruction, either individually or combined. In addition to the level of the obstruction, the type of collapse also determines the choice of the surgery, whether it's an anteroposterior collapse, a lateral collapse, or circumferential collapse. The surgical choices varies, which I will be dealing in the further slides when I will be highlighting these points. So coming to the first the palatal surgeries, the first operation, the uvulopalatopharyngoplasty, described by Fujita and Ikematsu. When it was first introduced, it came out with a great bang, and it was considered to be the panacea of treatment for the obstructive sleep apnea syndrome. But the problems encountered after the surgery led to its failure. We see the OSA patient, the oral cavity. The incision is marked on the anterior pillars and the ventral surface by the cautery. First the tonsillectomy is done, after which the superior part of the posterior pillar is now given an incision, and the superior part of the posterior pillar is sutured to the soft palate, and the lower part of the posterior pillar sutured to the anterior pillar. So the redundant mucosa is excised, and a tight single layer of mucosal closure is done. So the complications of the uvulopalatopharyngoplasty include, because it's a tight closure, dehiscence of the suture line usually occurs, severe postoperative pain for the next 2 weeks after surgery, nasopharyngeal stenosis also occurred commonly, hemorrhage in about 2 to 4% of the cases, and nasal regurgitation and pharyngeal discomfort was also another complication. So the disadvantages of the U-therapy operation especially was its achievement of cure rates. For stage 1 Friedman's OSA disease, it was successful in about 80% of the cases. However, in stages 2 and 3, it was less successful, and it achieved a success rate of only 38% and 8% respectively. So here in these stages, U-therapy may end up snoring. However, AHI had no change. The apneic episode did not have any change at all. Hence, several modifications to the traditional U-therapy has been advocated. One such modification is the uvulopalatopharyngoplasty Fairbanks modification technique. You see the OSA patient with a drooping soft palate and webbing between the uvula and the pillars. So first, a superolateral incision given on the soft palate on either side of the uvula, and then a box type of incision is made at the junction between the anterior pillar and the mandible, and then which is extended across the soft palate midway between the base of the uvula and the hot palate, so that it never extends goes above the midline. And then the redundant mucosa, the soft tissues, especially the fat, the glands, and the fibrous tissue are removed, leaving the musculature intact. Then you see, then the mucosa, the posterior pillar is advanced superolaterally, and then it's sutured to the adjoining anterior pillar and the adjoining soft palate. The dorsal surface of the soft palate is now moved forward towards the ventral surface of the, sutured with the ventral surface of the soft palate, thus increasing the lateral dimensions as well as the AP dimensions of the pharynx, so that adequate airway is obtained, and the rectangular appearance of the from the oropharynx, it prevents regurgitation. So this is the completed closure. So this is the Fairbanks modification achieved overcame some of the complications of the uvulopalatopharyngoplasty. The next procedure is the uvulopalatal flap, which is a less minimal procedure when compared to that of the Fairbanks modification technique. Here you can see the incision marked on the soft palate and the uvula. The lower part of the uvula is trimmed, whereas in the previous procedure the uvula was completely removed. Here the lower part of the uvula is alone trimmed. The mucosa is removed, from the incision side, along with the fibrous tissue, the fat and the glands. So the debulking is done, the muscular layer is left intact, and any bleeding points is cauterized with minimal, in less invasive cautery, less milder form of cautery used for ophthalmic surgeries. Now the dorsal palatal palate is now advanced to the ventral surface of the palate and sutured, mucosal edges of the incision sutured. The tonsillectomy, further the procedure is simplified by widened, the airway is widened by removing the tonsils and suturing the anterior and the posterior pillars, and then additional superolateral cuts on the soft palate also further helps in the shortening of the soft palate and widening the airway. So the xetopalatoplasty is the third procedure, which is the workhorse of any palatal level obstruction. The indications are Friedman's stage 2 and 3 disease. The main aim is to widen the space between the palate and the tongue base and both the anteroposterior and the lateral dimensions of the pharynx. In U3P operation, the Scott contracture vector is anteromedially directed pull. As a result, it eventually leads to nasopharyngeal stenosis. Whereas in xetopalatoplasty, the Scott contracture vector is anterolateral directional pull on the soft palate, resulting in increased dimensions anteroposteriorly as well as laterally, and that is why this operation is successful both for an AP narrowing, anteroposterior narrowing, as well as lateral narrowing, the lateral concentric lateral combined anteroposterior and the lateral narrowing, which is a concentric collapse of the pharynx. So that is why it's the workhorse of any palatal level obstruction surgery. Now the steps of the xetopalatoplasty, you see a butterfly shaped incision. The midline of the incision is just below the midpoint between the base of the uvula and the posterior part of the hot palate, and the lateral extensions are further extensions superolaterally. So the midpoint is made to, if we don't extend the midpoint of the incision just above the mid level, because if we extend it above the mid level between the base of the uvula and the hot palate, it may lead to a Gothic arch. As usual, we remove the mucosa, the glands, the soft tissue, the fibrous tissue, and the fat. We have debulked it and soft palate, and then the muscular layer is left intact. The uvula and the soft palate is divided in the midline. Now the two flaps are now pulled anterolaterally and then sutured to the mucosal edges. So palatal musculature is not resected despite adequate palatal shortening and the widening of the posterior airway space, and there is no velopharyngeal insufficiency as in U3P operation. So this is a very good surgery and widely used surgery for any obstruction at the level of the palate. Next comes the expansion sphincteroplasty, which is used specifically in a lateral wall collapse. If in DICE the type of collapse is only a lateral collapse and the anteroposterior diameter is maintained, then we do the expansion sphincteroplasty. Here the steps are: first we do a tonsillectomy. Then the palatopharyngeus muscle is dissected in the posterior pillar and transected inferiorly, and this is held with a silk suture. And then it is mobilized, and the soft palate incisions or superolateral incisions are made on either side of the uvula and soft palate, and the suturing of the palatopharyngeus muscle superolaterally to the soft palate muscles and to the pterygoid hamulus is done, so that a anterolaterally directional pull is achieved and a lateral expansion of the pharynx is achieved. So this is a very good surgery for lateral pharyngeal collapse. Another surgery which is widely used for lateral pharyngeal collapse is the lateral pharyngoplasty. Here we do a tonsillectomy, and the superior pillar superolateral cuts is made at the top of the superior in the anterior pillar at the level of the superior pole. So this exposes the tonsillar fossa completely and the superior constrictor muscle, which forms the bed of the tonsil. Next would be the dissection of the superior constrictor muscle, and finally it is divided. The divided superior constrictor muscle is sutured to the anterior pillar. Next, the posterior palatopharyngeal muscle, which forms the posterior pillar, it is everted and sutured to the anterior pillar on the soft palate anterolaterally. So thus we have a wide lateral expanding, the pharynx is expanded laterally on either directions. So this is especially useful for lateral pharyngeal narrowing. See, we have also other minor procedures in the palatal. They are the laser assisted uvulopalatoplasty, commonly called as the LOP. then palatal implantation procedures, then radiofrequency ablation, that is volumetric tissue reduction with minimal thermal damage of the soft palate, cautery assisted palatal stiffness operation, which is called as the capso, then injection snoroplasty and snare uvulectomy. All these minor procedures help in alleviating the snoring, but they are less effective in reducing the apnea hypopnea index. So if you want to relieve the patient from snoring, that is especially the upper airway resistance syndrome, it's a useful procedure. However, when the apnea hypopnea is very much elevated, I think we have to resort for the major procedures. So the lobe, the steps of the lobe, you see the laser vaporization points or the soft palate and multiple points and the para-uvular incisions, so that finally the shortened uvula and the stiffened palate is seen after the fibrosis of the healed fibrosis. Sometimes it may result in excessive mucosal ulceration of the soft palate and scarring, so it will be detrimental for the patient. So laser also should be used judiciously. Then contouring, though uvula has been can be contoured so that a residual uvula can be made into appearance, or sometimes to reduce the amount of ulceration and scarring, we can also do the anterior uvula and the soft palate mucosal vaporization in the midline with the laser, so that we can have a controlled stiffening of the soft palate. Then this implantation is a special gun is used to implant submucosally into the soft palate. They are nothing but polyethylene tetraphthalate implants, which causes inflammation, fibrosis, stiffening of the palate and decreased snoring as a result of the stiffening of the palate. Uvula can be snared, which is called as a snare uvulectomy, which when the elongated uvula is the main culprit in causing snoring. Then this radio frequency at multiple points in the soft palate, it causes it is less collateral damage when compared to the diathermy, traditional diathermy. So, and it induces inflammation and fibrosis, so stiffening of the soft palate. So radio frequency volumetric tissue reduction somnoplasty is very effective in reducing the snoring. Then we go to the hypopharyngeal airway surgeries. They are the genioglottal advancement procedures and hyoid suspension procedures, which mobilize all these two procedures. They mobilize the tongue forward. So another procedure is the reduction in the volume of the tongue, especially the tongue base. This is they are partial midline glossectomy, radiofrequency tongue base ablation, coblation ablation of the lingual tonsil, submucosally minimally invasive endoscopic lingual excision, and the tongue base suspension suture. So we see the radiofrequency tongue base ablation, where the electrodes is introduced underneath the surface deep into the muscular tissue. It should be done in the posterior third of tongue, or in the midline, or in the midline, or in the paramedian position, or it can also be done in the ventral surface of the tongue, depending upon where the enlargement of the tongue is. But it should not cross the paramedian position, as the lingual vessels and the neurovascular bundle is about 2 to 2.5 centimeter deep, and it may, if you are within the paramedian 1 centimeter paramedian position, it will these neurovascular structures will not be affected. Again, it causes inflammation, fibrosis, and reducing the reduction in the volume of the tongue base or the corresponding part of the tongue. Next is the submucosal smile operation, where the submucosally minimally invasive endoscopic lingual excision is done. This is combined with the lingual suspension suture, which is suture to that of the mentum, under surface of the inner surface of the mentum. So the tongue is pulled forward, and the posterior tongue base also is volumetrically reduced by excision of the muscular part of the tongue. This achieves good results in the experienced hands, so it should be done only with those persons with good experience. Next comes the mandibular osteotomy with genioglottal advancement, which pulls the tongue anteriorly and increases the retrolingual space, the posterior airway space. Here, a rectangular window is made just above the mentum, and which includes the genioglottal tubercle and its attachment. So this mandibular window is pulled anteriorly and twisted 90 degrees, so that the tongue is brought forward, and it increases the retrolingual space and the posterior airway space. So this is the mobilization of tongue which we achieved by this procedure. So the next procedure would be the hyoid suspension, where the hyoid bone is sutured to the thyroid cartilage through a transverse cervical incision. The hyoid bone is exposed, and the stylohyoid ligament is divided, but the suprahyoid musculature is not divided. Then two medial and two lateral sutures are made passing underneath the hyoid bone and through the thyroid ala, and they are sutured together so that the hyoid bone is brought to the thyroid ala, and this mobilizes the tongue anteriorly. So coming to the latest algorithm of managing a retrolingual, that is a tongue-based collapse. So it may be due to muscular tongue-based hypertrophy or a lymphoid tongue-based hypertrophy. If it is due to a lymphoid tongue-based hypertrophy, we can go for coagulation reduction of the lymphoid tissue, and so that we create an adequate retrolingual space. Or we can also use the advanced robotic reduction of the lymphoid tissue, which I will be dealing in the recent advances in the further future slides. If it's a tongue-based muscular hypertrophy, then we should know whether patient is having a retrognathia or there is no retrognathia. If there is a retrognathia, this patient is only suitable for mandibulomaxillary advancement surgery, that is the phase 2 surgery as advocated by Riley Powell. Or if there is no retrognathia, we do an indirect way of mobilizing the tongue by attaching a stimulator to the hypoglossal nerve. This is a very recent advance, so that it increases the tone of the tongue musculature during sleep, especially during inspiration, and hence the tongue will never fall backwards, and it maintains the posterior retrolingual space. So now we come, after finishing the phase 2 surgeries, we now reach the phase 2 surgery, that is a maxillomandibular advancement surgery advocated by Riley and Powell. The LEAF-4, it consists of the osteotomies of the maxilla and the mandible. In the maxilla, it is LEAF-1 osteotomy, and in the mandible, it is bilateral, sagittal, ramus split osteotomies. So the maxilla and the mandible is advanced forward and then fixed with plate and screws, so that it mobilizes the tongue as well as the short palate anteriorly. So this increases the posterior airway space, especially at the level of retroglossal and the retropalatal level. So it is the most effective craniofacial surgery for the treatment of obstructive sleep apnea syndrome, and this is directly we go to the phase 2 surgery in case of skeletal abnormalities, that is static obstruction. So the side effects of this maxillomandibular advancement surgery include malocclusion, which can be treated with prosthetics or occlusional equilibration. Transient facial paresthesia also have been reported. Mild speech and swallowing defects, and the patient has to get given adequate swallowing and speech therapy so that he gets adapted to the newer position of the maxilla and the mandible. This is the picture showing the mobilized maxilla and the mandible and fixed with a plate and screws. So the tongue and the palate is pulled anteriorly, increasing the posterior airway space. So now the recent advances are the less invasive methods, that is the barbed wire pharyngoplasty. Here the barbed wire pharyngoplasty is a surgical technique for treating OSA. We use barbed wires, so knotless wire. We never use knotless wires, and these may be resorbable or even not unresorbable sutures are also available nowadays, which stiffens the sauce and suspends the soft palate, leading to widening of the airway and also reducing the snoring and reducing the AHI. It's a very good surgery, and it's a less invasive surgery also, less morbid surgery. It's an invasive surgery, but it's a less morbid surgery when compared to the other surgical procedures. Now coming to the next advanced surgery is the Wood's transpalatal advancement pharyngoplasty. Here a mucoperiosteal flap of the hard palate is elevated, exposing the posterior part of the hard palate. Now a segment of the bony hard palate is removed, and now the soft palate is advanced anteriorly and sutured to the residual hard palate by making suture burr holes in the bony hard palate and pulling the soft palate anteriorly. So it increases the retropalatal space. Another recent advance is the coagulation assisted tongue based reduction. So these are all substitute for the traditional diathermy, where here we use the saline as an intermediate and the breakage of the sodium chloride bonds, heat is generated that, and this causes the coagulation of the tissues and destruction of the tissues, and with less thermal damage and less collateral damage. So that is when compared to that of the radiotherapy. So I will show you a video showing this coagulation assisted tongue based reduction. So this is the coagulation band used after a patient is in general anesthesia. So it's a prominent lingual tonsillar hypertrophy, prominent lingual tonsils are there, and it is used in a coagulation fashion. So where we reduce coagulate the lingual tonsils. So reducing the tissue there, as a result we increase the posterior airway space at the retrolingual level, and thus the patient gets benefited, and the edema also is very less when compared to diathermy, and hence the postoperatively the patient feels better and gets relieved of the snoring, and also the AHI gets a marked reduction in the AHI also occurs. Only proper selection of the cases, identification of the level of the obstruction is very, very important. Again and again, that's why a good preoperative drug-induced sleep endoscopy is very much essential. So I'll go to the next procedure, the coagulation-assisted glossoepiglottopexy, where the epiglottic collapse occurs. So here, as I told you, as I highlighted in the beginning itself, epiglottic collapse is a condition where you should diagnose only by DISE, and if you without doing DISE and you are not identifying the condition, and if you prescribe the CPAP, it will be detrimental to the patient. It aggravates the hypopnea, and it may result in mortality also. So that is the importance of this condition. So I will show the video of this condition. Here again coagulation is used. So you can see the coagulation being done on the dorsal surface of the epiglottis in the linguoepiglottic sulcus in the vallicular region, and the dorsal surface of the epiglottis, and there is also some lingual tonsils, so adjoining lingual tonsils also coagulated, so that a raw area is created in the adjacent and the dorsal surface of the epiglottis and the posterior base tongue. So two raw areas in the adjacent meeting points will lead to addition of the epiglottic fibrosis and addition of the epiglottis to the tongue base, and thus it prevents the glottic collapse. Then next is the coagulation assisted supraglottoplasty, where the ariepiglottic folds are very narrow. So you can see the video there. See, the ariepiglottic folds are divided with the microlaryngeal surgery being done, where the ariepiglottic folds are divided on either side with microlaryngeal scissors. You can see the endotracheal tube inside the laryngeal inlet, and the inlet being packed with silk threaded gauze to prevent the gauze being dislodged into the lower trachea. So now after dividing the ariepiglottic fold, there's some amount of soft tissues will also be coagulated. So we create an adequate, so the epiglottic collapse is prevented by dividing the ariepiglottic fold and removing the soft tissue in the ariepiglottic fold. Now coming to the next recent advance, the hypoglossal nerve stimulation. It's a very promising new therapy. It can be done unilaterally, which was brought out by the company Inspire, and bilateral, which is brought out by Genio stimulation device. It is I think it is US FDA approved. Now bilateral stimulation devices are more advantageous because it stimulates the hypoglossal nerve, especially during inspiration, and the tongue, the muscular tone of the tongue is maintained, and prevents the falling backwards of the tongue during sleep, and maintains the posterior airway space, especially at the retrolingual level. So this is the surgical photo showing the electrode being attached to the hypoglossal nerve, the implanted electrode being attached to the hypoglossal nerve, which stimulates the hypoglossal nerve during inspiration. So another recent advance is the transoral robotic surgery. Here, the dissection of the lymphatic tissues in the base of the tongue from foramen cecum to the base of the epiglottis is done on both sides up to about 1 to 1.25 centimeters. And we remove, in addition to removal of the lymphatic tissue, we remove a layer of the muscle up to 10 millimeters on either side, beyond which we may encounter the lingual artery. Beyond 10 to 12.5 centimeters, the lingual artery comes. You may damage the lingual artery. That's very, very detrimental. So you should not cross the 1 centimeter on either side of midline. Additional 5 millimeter layer of muscle is also removed in the midline, so that we remove a volume of about 10 ml of tissue. Then only you will have tangible, successful results. Less than 7 ml of removal will lead to unsuccessful results. The picture showing the robotic device and equipment. It's a very costly equipment, and but we can do it. Surgery is done in a controlled fashion. Finally, we are having I have completed all the gamut of surgery which is available, and it is the surgeon who makes the appropriate choice based on the factors which I have discussed during my talk. So to summarize, the surgical treatment is contemplated in moderate to severe OSA, a milder OSA with excessive daytime sleepiness even when the AHI is less than 15, OSA with cardiac abnormalities, failed or non-compliance to CPAP. The surgical treatments depends upon the type of obstruction, whether it is static or dynamic, so that we can go for phase 2 or phase 1 and surgeries. The level of obstruction, so that palatal surgery, lingual surgery, retrolingual surgery, and the type of collapse, whether it is a AP collapse, concentric collapse, or a lateral collapse. And finally, the BMI also plays an important role. For BMI greater than 40, always bariatric surgery is the treatment of choice. Upper airway surgery is absolutely contraindicated. Thank you. These are my references. Thank you.